Good morning, delegates and friends. Uh, Being the first session of the day, I think we are mostly the speakers who are here. Quite understandable after a hectic evening cultural program and things like that. People are still sort of waking up and having their breakfast probably. So we'll start the session. This is regarding phakic IOLs. In fact, I heard there's a wet lab being conducted by Star in one of the stalls. When I asked them what is the reason, because earlier it was like ICLs are only provided to people who are accredited. So 20 years back, there were very few ICL accredited surgeons in a city. So now probably they want that hesitancy that is associated with phakic IOLs. There are a lot of surgeons who are willing to take it up, but then quite a few of them are a little hesitant how to handle them, how to load it, how to inject. So when most of the videos are shown, people talk about the risks and difficulties of doing the surgery. Actually, it's a very simple procedure because unlike cataract, you don't have to spend too much time working with the machine or anything like that. You just put in the implant. So today we are having we have four speakers. In fact, Dr. Mathew is laid down with fever, so he couldn't make it. So that topic also, I've borrowed his slides and I'll present a few slides from that. So we are going to talk about just not the foreign implants, we are also talking about the Indian implants. We have some of the best surgeons in South India and Kerala. And special welcome to Dr. Anand from Coimbatore. He's a senior surgeon in Lotus Eye Care Hospital, Coimbatore. I was also working there till 2006. And he's been there for quite a long while. Welcome, Anand. And Dr. Jason, one of my gurus, teachers, guides, a brother to me. Any time of the day, even in the night, I can call him to find out what I need. If I have any difficulties, I always discuss with him. Such a humble person that I have known. So he's here to give his views regarding the Indian lenses like IPCL, which he has done in hundreds probably. And Dr. Jairam is the owner, the founder and director of Precise Eye Hospital, Trivandrum. They have quite a few branches all over the southern part of Kerala, and he's operating in most of the centers of Precise. Welcome, Dr. Jairam. He probably is the person who first showed me refractive, like even LASIK and ICL when I started. Jairam actually, even now he shares his views whenever I have a doubt regarding all these surgeries. Even cornea, he's a good cornea surgeon. So we'll get to hear from him regarding Star ICL and his experience regarding that. So let's start the session. First is an introduction regarding phakic IOLs, which will be dealt with me, and then we'll go on to Dr. Anand after that. So I just would like to give a kind of introduction here regarding what phakic IOLs are, and a little about the refractive surgery. So basically it's a reshaping of the cornea that is done in all laser surgeries. And Jose Baraka was the first one way back in 1948 to show the concept. Like, he did scraping of the cornea, and later with microkeratomes, he did the surgery. Later on, radial keratotomy by Fedorov. You would have heard of him. In Russia was the next kind of refractive surgery that was very much prevalent, where you make 90% cuts in the cornea, multiple cuts, from 8 to 16 cuts are made. And then, you make the central part of the cornea flat. And Payman patented the laser that could reshape the cornea in 1989. But FDA approval for LASIK came quite late. That was in 1998 that the company called Laser Sight Technologies came out with LASIK, which was approved by FDA. So the other LASIK, the laser-related procedures, as you know, are PRK, transepithelial PRK, LASIK, and EpiLASIK and SMILE, as you know. And also intrastromal corneal rings intacts can be done to flatten the central cornea. So these are the other procedures that I just want to mention. And then earlier, just before LASIK and all the phakic IOLs came, we used to do lens extraction with implantation of different kinds of lenses, monofocal and also multifocal IOLs. Extreme powers, of course, multifocals are not available, but this was an option long time back, and even now, if all these gadgets are not available or the phakic IOLs are too expensive for you. So LASIK came with a lot of risks as well as disadvantages like overcorrection, regression, flap-related complications, and extreme change in the corneal shape. So it was a sort of irreversible kind of change that was happening in the cornea. And then post LASIK, like if you get an eye with cataract, even IOL calculation used to be difficult. So all spectacle powers above 7 or 8 where LASIK could not be done, this was the alternative. Phakic IOLs came into existence, where cylinders also can be corrected either in combination or in isolation. So different lenses that came into vogue are, as mentioned, it could be placed either in the anterior chamber, or it could be an iris clip lens, or it was a posterior chamber lens that was to be kept as a phakic lens. So these are the different lenses that we have seen over the last 20 years. Verisys IOL, again FDA approved, was a iris claw lens. Quite a few eyes were done. A lot of corneal decompensation, lens-related problems like losing grip on the iris and the lens getting dislocated in the anterior chamber, and all the complications related to that. Plenty of them were there. Then the angle-supported AC IOLs that came out around 2009. It died fast within a few months. I think India hardly had any of these lenses implanted, very few, if at all. And then the PC IOL, that is star ICL, is what has been used over the years, and it has been refined. The design has changed a lot, and that has almost come to be very established. So the indications are the age, anything above 18 or 19, when the refraction has become stable. And the anterior chamber depth should be about 2.8, angle more than 30 degrees. Corneal endothelium should be healthy, and a mesopic pupil size of less than 5 millimeters is ideal. So these are the contraindications. Any anterior chamber inflammation, glaucoma, macular scars, all these are rejects. You can't go do such an expensive surgery where the outcome won't be good. And also systemic diseases like diabetes, connective tissue disorders, and autoimmune disease. So these are the formulas that are followed in ACIOL and PCIOL. And often what we do is we take the measurements and hand it over to the company. They come out with the custom built kind of lens that is best for the eye that we are going to do the surgery. This is a picture of the anterior chamber angle supported lens, and this was brought about by Acrisoft, and 4 models are there depending on the size of the white to white. And this is the design of the Verisys lens. It's a single piece PMMA lens. the wound should be around 5 millimeters or slightly more than that. And so the scleral tunnel is what was preferred. And then this is the Star Vision ICL. It's a collimer that the company has come out with, and it's a lens that rests in the sulcus behind the iris, and it's implanted through a 3 millimeter incision. So the steps that are very should be taken with caution is, like, do a good refraction, a preliminary workup as you do in laser refractive correction, including topography, specular microscopy if available, good dilated fundus examination by your retina surgeon, and the pupil size is measured, and white to white distance is also measured, and make sure that it's not a dry eye that you're operating on. Intraoperatively, loading of the lens is to be done with a little care, because it's a very ultra thin lens, and also the tunnel size, as I mentioned, should be 3 millimeters or slightly more, so that the nozzle can be introduced into the anterior chamber before the injection of the lens, and under normal viscoelastic HPMC 2%. Gentle unfurling of the lens in the anterior chamber and fixation, that part is also a little, has to be done with care, so that you don't injure any of the structures inside. And if need be, a peripheral iridectomy was done till the new lens, new model with the central hole in the lens came out. Centriflow it was called, and that actually we don't do a peripheral iridectomy anymore. So post-operatively, one has to follow up for glaucoma, any signs of ill-fitting lens. A vault has to be checked, and the IOP has to be measured over the next few months, and probably a 6-monthly follow-up for IOP check and specular microscopy is what is required even post-operatively. So risks are, as already mentioned, glaucoma is a probability if there's an ill-fitting lens, the vault is too much. Iritis if the haptics are going to rub against the iris, and pigmentary dispersion and such issues are there. And endothelial cell loss is always a possibility, so one has to be careful, following up the patient and make sure. But then it's been at least 10 to 15 years since the first few lenses were implanted, and most of the patients are doing perfectly fine. Retinal detachment and then dislodgement of the lens, as in the case of iris claw lens. So it's turned out into a major boon, and it's a reversible procedure. It's a major advantage in high and extremely high myopes, hypermetropes, and astigmatic eyes, on which laser surgery is not possible.